how it really works is if you take somebody at a baseline level and you measure their vitamin D and it's low, and you put them on a standard dose, say 5,000 units for 3 months' time, at the end of 3 months, and you measure it again, that's where they're going to be.
Specific to pregnant and lactating women, the recommendations are that a pregnant woman can take up to 5,000 international units a day.
All this is Dr. Mobeen Syed from drbean.com. Welcome to one more show. So today with us, we have esteemed guests, long-term researchers, physicians, practitioners who have been helping humanity, children for a long time, and have been looking at vitamin D for a long time. And there have been some recent news coming out of Endocrine Society, some recommendations coming out, then Cochrane review. And I think it is the right time to talk about these things. So without delay, let's start with brief introductions. So Dr. Carol Wagner, let's start with you. Tell us about yourself.
Okay, well, I am a professor in the Department of Pediatrics at the Medical University of South Carolina, and I'm an attending neonatologist. And I have worked with Dr. Bruce Hollis for the past, oh gosh, more than 20 some years, conducting vitamin D research in pregnant and lactating women and their infants.
Thank you very much. Welcome. And I always say this, guests like you and Bruce and Jen, you increase the ambience of our neighborhood, the Dr. Bean neighborhood. Your research and your busyness is actually, if we Google you, it is all over the place. So thank you very much for finding time for us. Bruce, thank you very much for joining us. And we know a little bit about yourself as well.
Yeah, so I'm a PhD researcher. I've been at vitamin D, studying vitamin D for almost 50 years. And I'm now professor emeritus. I went emeritus status about 3 years ago. And I still continue to be active on things like these webinars. I'm not doing a lot of active research anymore in our laboratory. And I've researched with Carol Wagner for the last 20 years in pediatrics, but I was involved in the development of the blood testing since the beginning for the vitamin D compounds. And then did a lot of collaborative research with the Harvard School of Public Health on vitamin D in cancer and heart disease. And like I said earlier, involved with Scott Weiss and the VDART, large VDART vitamin D antenatal asthma reduction trial at Harvard for the past 15 years, which was really a remarkable trial in a lot of ways. And I guess we'll talk some about that as well.
Understood. Thank you very much. And thank you for joining us, giving us your time. And Jen, you have been the heart and soul of these series, these talks. You are the one who initiated this whole thing for us. So tell us about yourself and what is your motivation for these talks?
Sure. So I'm Jen Aliano. I am currently the director of GrassrootsHealth, and GrassrootsHealth was founded in 2007 by Carol Baggerly with the purpose of just really shouting from the mountaintops the importance of vitamin D and the findings that these researchers had already been getting in their studies, but just hadn't been reaching the mainstream. And back in 2007, there was already so much amazing research about vitamin D in cancer, vitamin D in prenatal health. So GrassrootsHealth has been running an international, we call it a public health intervention study on vitamin D. And we've had people from all around the world who test their vitamin D level at home, answer an online questionnaire, and we've been able to publish papers on that. We've worked with doctors Wagner and Hollis. They're both on our vitamin D scientist panel. And we also initiated a project at the Medical University of South Carolina with Dr. Wagner, where we were able to change the standard of care for all prenatal women to include vitamin D testing as part of what all the women got. And we had some amazing findings from that project, which I think we'll discuss in a little bit.
Understood. Thank you. And thank you very much for your time, for joining us. And thank you very much for helping us do this series. So I'm going to start with Dr. Wagner. So Carol, tell us, what is the current state of affairs in the light of the new recommendations that came out?
So specific to pregnant and lactating women, the recommendations are that a pregnant woman can take up to 5,000 international units a day, and that there's no need for vitamin D status testing, that you really, you can prescribe, the clinician can prescribe, just continue with prenatal vitamins, or based on maybe their review of the literature and so forth, could give safely up to 5,000 international units of vitamin D a day.
And so what bothers me in this is the recommendation not to test. How is it possible that for us to start dosing something without knowing what are the baselines? Is this me who's just naive?
My experience is that we certainly have the literature and the data to support it, that an individual will start, there's a great deal of variability. And we have seen certainly that there are certain groups that have a much higher risk of vitamin D deficiency. And as we know, if you don't go out in the sun, and if you have darker skin pigmentation, or you have a higher BMI, you're at greater risk of vitamin D deficiency. But even if you look at individuals within a given socioeconomic status, racial, ethnic group, you see a great deal of variability. And I think that the issue is, so if you give a blanket, let's say 4,000 international units a day, which we certainly showed was safe and effective, there were about at least a third of the women that by 20 weeks of pregnancy hadn't achieved sufficiency. So having levels, and Bruce, you can certainly maybe, give your perspective on this as well. But by measuring a 25 hydroxy vitamin D, which is your indicator of vitamin D status, it really does give you a much better perspective of the person's status.
Makes
Yeah.
sense. Yes, please.
There's a high variability of response to vitamin D. I mean, if you look at the grassroots chart on supplementation and levels achieved, there's thousands and thousands of patients on there. And these are pretty motivated people. They take their supplements every day. They have their blood analysis run, and there's tremendous variability. So what one person requires 5,000, the next person might require 8,000. And to get to your point about in pregnancy, so when Carol and I started the first pregnancy trials almost more than 20 years ago now, and it was, we wanted to give 4,000 units to pregnant women. And at the time, the UL was 2,000. And so we had to actually write an investigational drug application to the FDA that took us 6 months, just like a drug company would have to do, to get approval to do this. And of course, and it was all FDA monitored all the time, everything, safety. And we never saw any indication that vitamin D at the levels we were looking. So, and I'll go back to the VDART study, that vitamin D antenatal asthma reduction trial at Harvard. So a lot of people used our IND to do their studies back in those days because they could just apply and without going through what we had to do. And so Scott Weiss, who ran that study at Harvard, used 4,000 units. And at the end, in the article he just published in Journal of Allergy and Clinical Immunology, which is a fantastic synopsis of that, he actually says that to really get women to the level that we wanted to see, we needed at least 6,000 units a day. So that would have been unheard of, probably even more. Okay, and there's no indication that any of this is harmful to anybody. Okay, these intake levels take people to naturally the upper levels sometimes of naturally occurring vitamin D in sun-rich environments. So, again, it comes back not knowing the blood, blindly going on a blood level without knowing. I mean, how it really works is if you take somebody at a baseline level and you measure their vitamin D and it's low, and you put them on a standard dose, say 5,000 units for 3 months' time, at the end of 3 months, and you measure it again, that's where they're going to be. That's their study. If you want it to go higher, then you need to supplement more vitamin D. For my own personal opinion, my own personal point, I take 10,000 units per day to maintain my blood levels at about 80 nanograms. Well, not everybody needs that much. If you, again, look at the Grassroots chart on what people take and what their vitamin D levels achieve. So I don't think it's necessary to be vitamin D tested all the time, but you need at key points to be tested to know on a given dose where you fall, because it's very individualistic.
Right. I have
Makes
a
sense.
few questions to ask. First of all, what is that target range that you would recommend for pregnant women, the minimum level?
Again, I'll go back to the Wise study, and 50 or 60 at a minimum.
And again,
nanograms per ml.
And the dose required to get there is going to be different from one woman to the next. It can
Yes,
vary
absolutely.
by up to a factor of 10, 6, depends on so many
you only
factors.
know if you have an actual measurement after a steady state period.
Right.
So I have a burning question, Jen, before you go on. Sorry, I have a very important question, which is kind of bugging me. And that is when, and we'll discuss more as well, and there will be a lot of information for why this is important, vitamin D, and for pregnant women and for newborn. The question is, why do these societies or these recommendations come out, and they come out so differently or even flying in the face of all of this research? Is there a reason that this happens, which is not scientific? Because it doesn't look scientific to me, these recommendations. Why does this happen? Did they choose studies that were providing them a narrative? Did they already have a narrative and then they fit the studies to it?
Could I answer that from the standpoint of the recent Cochrane review?
Please do.
All right. So the Cochrane review from, I don't know when the last one is, in 2015, 2014, and it was fairly positive for the use of vitamin D during pregnancy, and again called for more studies to be done. So a year ago, I got asked by Cochrane Review to review the one that they just were putting out, that they tried to publish. And there were six of us on the review, or 3, I would say, prominent researchers, including myself, and three other people that were cursory reviews. Looked like they didn't even have any questions. They just basically said, accept the article. But there were 3 really critical reviews. And while nobody rejected the review outright, there were serious questions for major revisions from all 3 investigators. Okay. Nothing went on for months. Okay. We could access the Cochrane review, see where it was going. Nothing. Okay. And then one of the big complaints is that from the original review several years ago to this review, they eliminated like 20 studies. This took them out. They said they didn't meet current criteria. They included some other ones. They left out some really critical, good studies from overseas for reasons I could never figure out. And then they went back to the authors and the reviewers, as far as I know, and I know myself and Stefan Pilz in Austria, never saw those reviews ever again. So they never sent us back. They never sent those revisions back to reviewers for any more comments. And I had never seen anything like that happen before in peer review.
Understood. Thank you.
Huh?
Please.
Yeah. So I'd never seen anything. So there was some sort of interference. I mean, they basically said, yeah, vitamin D is probably useful to being pregnancy, to saying, now we don't think it's a value. And then they, at the end, of course, it's always calling, we need more investigation. But I can tell you right now that that's not ever going to happen because there's no money to do it. We got our money to do these studies by NIH years ago. That's never going to happen. So you're never going to have high quality studies because nobody's ever going to pay for that. And they know that. Okay, so it's gaslighting when they're calling for more studies because they're not going to happen. So you have to make recommendations on what we know. And we thought about writing, Pilz and I, a letter to Cochrane, but they probably will not publish it. But I never saw anything like that, where reviewers had really major concerns and never saw the revision of the manuscript before it was published. So you have to draw your own conclusions about what
makes sense. And it always kind of makes me wonder whenever they write at the end, well, there is more research needed, or we need more studies, and they just dismiss everything that is present. We have literature, so much literature that easy, good decisions can be made. So thank you very much, Bruce, for that. Back to you, Jen.
Okay, yeah. And I just wanted to point out the findings that both of you, Dr. Wagner and Dr. Hollis, you've had some pretty amazing findings in your trials. And a key point that I want to touch on, for example, with one of your preterm birth trials, when you analyze the data, and this is another reason that measuring levels is important, especially in research for health outcomes, as well as measuring levels to help determine a personal dose. When you analyze the findings from one of your trials for preterm birth, based on the dose given, there wasn't much of a difference there, correct? But then when you reanalyze those findings based on the serum level achieved, there was a very statistical difference. And so could you just speak to the importance of measuring levels in terms of vitamin D research, not just in terms of dosing?
Just one note about that is that in randomized controlled trials on dosing, you don't know who's taking their dose and who's not. They can, their subjects say, yeah, I'm taking my dose, and you can do pill counts and you can do all this. You don't know what people are really doing. But when you measure blood levels, it gives you a much better idea. So somebody could be on the treatment group of 4,000 units a day, and they never took pill number 1 for the whole time, but they still remain in the trial. Okay. And this is a problem with any randomized controlled trial of drug use. It's just not vitamin D. So in the case of vitamin D, you can actually measure the levels. And so the levels that are higher, presumably, are the ones that are taking the higher dose. And so that's probably one of the key issues. Okay. It's a better indicator of compliance than, yeah, I took all my pills.
But what about findings, the health outcomes, and the importance of dosing to reach a specific target level?
Oh, yeah, I mean, Carol can speak to that as well, but I think it's very important. And you're right. I remember that graph, and it shows preterm birth rates dropped as vitamin D levels rose. Mm-hmm. It was quite dramatic.
And there's a threshold effect, and you see that really 40 nanograms per ml, which is 100 nanomoles per liter, is really, sorry, my acting up here in the NICU. But that is linked with preterm, the risk of preterm birth. And we've published on that. And if you combine our data sets so that you have a larger sample size, you see that. And I did want to make this one point. There is a tremendous amount of basic science and translational research that's been amassed. I mean, literally thousands of papers that show the effect of vitamin D on specific cells and interactions, gene expression, up and down regulation, and so forth. And, how do you explain those findings and dismiss them in the case where a randomized controlled trial they'll say this is ineffective in changing the health outcome, and if you look at really the studies, we were never powered to I mean, we would have had to have many thousands of mothers, pregnant women enrolled in the study, and so it was only combining our data sets that we were able to show. And again, as Bruce said, show a difference that those who were vitamin D replete were less likely to have preterm birth after controlling for, a lot of many socio-demographic data. And again, intent to treat versus looking at it per protocol and did someone actually achieve the level. And if you start out replete, that's going to be very different than someone who is deficient and then achieves sufficiency. And I think there are many variables, whereas a classic drug study, you start out, both the treatment and the control group start off with a zero level of the drug in question. With vitamin D, it's a pre-pro hormone, and so you see variable amounts of vitamin D in a particular system, and so you really have to control for that.
Mhm. So you can't really look at vitamin D trials the same way that you look at these drug trials. And isn't that still how they tend to look at them in these
Yes.
big
Yeah.
reviews? And
Yeah,
then the other, oh, go ahead.
not along that's a really important point, because if you try to publish your findings in New England Journal or JAMA or British Medical Journal, and you want to, on your our randomized trial or any randomized trial, and you want to do baseline control and intent to treat, they won't let you do it. That violates the intent to treat model, and you're not allowed to do that. And in truth, what that does is it destroys a study. If you do baseline corrections, you don't need to do it in drugs. They don't drug trials, statins. You don't have it there in the first place. So these randomized trials were never meant for nutrients, although they treat them that way. And if you even try to correct for that, they eliminate. You get rejected. Okay, no, you can't do that. When in fact, it needs to be done to really see the outcomes of the trials.
And then
Sorry, please.
Yes, a key thing with vitamin D, not only is it a nutrient, everybody's either getting it from the sun, a little bit from their food, even if they're not taking supplements, but isn't there something unique during pregnancy when it comes to vitamin D, where by the end of pregnancy, we're not talking about the vitamin D that you take, the D3, but what the body converts it into, the hormonal form of vitamin D, the 125. Wouldn't the level found during pregnancy actually be toxic to a non-pregnant individual? And that's the only time in the entire life cycle that this happens. There's something unique about vitamin D in pregnancy. Could you address that?
Yeah, so that's what you're talking about is vitamin. You have the vitamin D, which is a parent compound, which we take in vitamin pills. D3. And then you have the intermediate form in the body, which is converted to 25-hydroxy-D. And that's the form that's measured when you go to have your blood levels measured. And then there's the hormonal form, which is 125 dihydroxyvitamin D, which is rarely ever measured because it really doesn't give you a lot of clinical information. But during pregnancy, and this remains unknown, okay? We know that during pregnancy, and we don't know why, that 125 levels go to levels that would kill a normal person. And by mistake, I've had ladies call me that the doctor measured the wrong compound, and it was 125, and it came back hugely toxic. And these women are frantic, and because their physicians are saying your vitamin D toxic, you got to stop right now. And it's just ignorance of knowledge, because they measured the wrong one, and that's what happens. Where this hormonal form during pregnancy goes off the charts. We don't know why. We don't know what drives it, and we don't know how pregnant women tolerate it at those levels. So it's not, I can tell you, it's not there for calcium homeostasis. It's there for other reasons. For, placental imprinting, for immune control. No one knows, but we do know that the levels during pregnancy of the hormonal form are massive.
So in other
Understood.
words, there's a very unique need for vitamin D during pregnancy based on that physiology. All right, Go
Yes.
ahead, Dr. Syed.
Thank you, Jen. This is fascinating. I actually did not know this. So thank you so much for this piece of information. I wanted to quickly engage our audience as well. And this is our trend. We do this. We have audience questions and we ask them in the middle as well. So if you give me a chance to ask a couple of questions, Jean says, what are some of the individual differences that affect how a person's body metabolizes and stores vitamin D? And I believe Bruce and Carol, you both are researchers and you both are capable of answering this. Whoever want to take it.
Obesity certainly is a factor, a body mass index. So if your body mass index is excessive, then your intake of vitamin D needs to be more. We don't exactly know why that is. It could be sequestration in the adipose tissue, but it requires a lot more vitamin D if you have BMI. And there's another important thing is magnesium status. You need to, magnesium is one of the things that I take. I take 400 milligrams a day.
So I would say that the factors that influence your vitamin D status, certainly your genotype, so your vitamin D binding protein, which is the carrier protein, so your vitamin D, the parent compound, and your other forms of vitamin D are carried by albumin and vitamin D binding protein. And so there are different genotypes, and that can affect kind of how much you release to a cell from that. Bruce mentioned BMI, whether or not you go out in the sun. If you use sunscreen, so sunscreen will block your synthesis of vitamin D, and diet really provides you with very little vitamin D. So our main source of vitamin D is from sunlight exposure. And there are, so those people who spend more time outdoors are going to have higher levels of vitamin D in their blood. If you look at those who are sunbathers and don't use sunscreen, those who are lifeguards versus those who have chronic diseases and may have sensitivity to the sun and never go out, they're going to have the greatest risk of vitamin D. And then during pregnancy, the mother, and also during lactation, for the most part, the mother definitely during pregnancy is the sole source of vitamin D for her growing fetus. And as Bruce mentioned, whereas the active form of the hormone 125 dihydroxyvitamin D is 2 to 3 times what you would see in a non-pregnant individual, that level is also elevated in the fetus until birth, and then it in both the mother and the newborn after birth. The 125 will drop down to a normal level. And so the point is, and then during lactation, we've certainly done studies with that. Vitamin D is going to be affected, and it's really the vitamin D, the parent compound, that's transferred into the milk more than the 25 OHD. And so the mom needs to be on a daily source of vitamin D to get that into her milk. And that's a whole other topic.
Understood. Thank you so much. I just have one more question, and then Jen, back to you. The question is from Mrs. Ayers. She's saying, what form of vitamin D do you suggest for women? Please comment on K2. Do they also need to take K2?
You want to take vitamin D3, which is almost exclusively what you find in vitamin supplements now. And I can't really make a comment on the K vitamins. We just haven't looked at them, and it hasn't been the focus of our interest. So.
Understood. And our last discussion with Dr. Vimala Vansa, we did touch upon the K2s as well. So Mrs. Iyer, if you watch the previous video, which will be published soon, I think it is already published on drbean.com. You can see the answer there as well. Jen, back to you.
Yeah, I wanted to make a couple key points. The first, Dr. Hollis, you started to talk about magnesium, and that is a very important cofactor for vitamin D. In our own study, we have seen that people who have been supplementing with vitamin D and they don't see their vitamin D level rise, oftentimes that can be due to a magnesium deficiency. They're not getting enough magnesium in their diet. And when they begin to take magnesium, we've seen their levels increase. The other key point that I would like to touch on is skin color can be another factor, a big factor, and increase the risk of vitamin D deficiency, because the melanin that makes the skin darker acts like a natural sunscreen. And so women who have darker skin need to be out in the sun longer than women with lighter skin to make the same amount of vitamin D. And we see a lot of these discrepancies between Caucasians and Blacks in health outcomes. And a lot of them are prenatal and maternal health outcomes. And a lot of vitamin D experts think that this could be due a lot in part to vitamin D. And if you look at vitamin D levels, some research has shown if you analyze these certain outcomes, cancer mortality, preterm birth, by vitamin D serum level, you see that discrepancy almost disappear. Go ahead.
Well, I would say that we talk about health discrepancies and on outcomes that aren't even amongst racial groups. I would say that there are many factors, but right at the very top is the difference in vitamin D status based on skin color. Whether it be cancer, whether it be diabetes, whether it be pregnancy complications, there is no single factor more important than vitamin D is. And that's just, you can't really even talk about it much anymore. And COVID was another one. When COVID hit, I went straight to see who was being hit worse. And of course, it was the African American population. And to us, it was because that population is so severely deficient in vitamin D, which is a key immune control point. But it's just, it's so apparent to us and so not want to be talked about.
Understood. So you'll be happy to know that during COVID, I did a lot of vitamin D talks, and I also presented some studies that showed the correlation of COVID, severe COVID, and the vitamin D levels. So we did our job, and I think it was helpful for many. So I have a question. When this is such an important topic, when this is such an important level to maintain, and it is such an inexpensive thing to do, why isn't it, why is it every individual physician's or individual person's job to figure it out and then adhere to it? I do not know how many people would watch this video, but this message isn't going out to a lot of people. Why isn't the Endocrine Society or other organizations actually trying to help? To me, it seems like they are countering it. Why? It is harming people.
I can't answer. I mean, I think that powerful people within those organizations are trying to protect their turf on what they believe, whether it's the Institute of Medicine or whether it's the people who ran Vital trial out of Harvard. Everybody has their own turf to protect, and I think they look at very bad studies, or they're on the periphery of looking at this and saying there's not enough randomized trials. I think one of the really tragic things is that they totally discount retrospective or observational, really high quality trials. And again, I'll go back to asthma trials in pregnancy. When Weiss and his group are looking at observational retrospective trials and seeing tremendous prevention, and then moved on to randomized trials which weren't nearly as effective unless they did the change and did baseline controls. But because I think in those cases, the observational trials are actually of higher quality because it measures lifestyle. It's what those people work always, not for a short period of intervention that might or might not have been enough. They might not have adhered to it. And so I think to make these, everybody looks at randomized trials, no matter as the end all be all. And if they don't work, it doesn't work. They need to look at the high quality observational retrospective trials coming out of Physicians Health Study, Nurses Health Study at Harvard, and look at those trials and use those more in what we make our judgments on how much vitamin D we need or don't need. And they don't. They just discount them.
One of our other vitamin D scientists on our panel at Grassroots Health is Dr. William Grant, and he wrote the Vitamin D Misinformation Playbook, I believe over a decade ago, that talks about how, and I hate to throw it in here, but big pharma, there's a play against getting vitamin D, this research into the mainstream, and I think he would be an excellent person to have on and speak to this. But I don't think we've touched on the findings, the published findings on the health outcomes in pregnancy that vitamin D can actually affect. I mean, we've briefly spoken about asthma. We've talked about preterm birth, but there's other studies showing vitamin D can affect preeclampsia, can affect low birth weight, can even affect the newborn's health. Can one of you speak to that? And maybe even Dr. Wagner, when we were running our project at the MUSC, and we were getting many women up to at least 40 nanograms per milliliter. I know we published our findings on preterm birth, but there had to have been many other observations between the health outcomes during the project versus since it's ended. But I'll let you. It looked like Dr. Hollis. It looked like you had something to say.
Well, so again, I'll come back to VDART and the importance of when to give vitamin D during pregnancy. Okay, I mean, a lot of trials, we tried to get women in as early as we could the first trimester, but even at that, 12 weeks have gone by. A lot of developmental stuff has come and gone. And so one of the interesting things in the VDART study was they had all baseline levels. So when women came in, their baseline levels were measured. Okay, and they published a paper in the Journal of Clinical Investigation, which is really high quality. And what they found was if they looked at preeclampsia at the end. Any woman who came into the study who had 40 nanograms of 25D or higher, and this is before anything was done, this was their entry level, not one single of those women developed preeclampsia. Not a single one. By statistics alone, on that group of patients, probably 10 of them should have, if it would have been not effective. And it was interesting. So when it was published in JCI, they made us remove that. Okay, they said, no, you can't put that, you can't say that in there. You can't show that there were no preeclampsia. So what that told us was that vitamin D was having a profound effect from implantation, prenatal, okay? So you needed to be that before you ever got pregnant. And, you know, that's where trials should be. You want to have optimal vitamin D from the time that you conceive, okay? And that would be highly effective at preventing preeclampsia and probably other things as well. That study's really tough to do on a randomized trial basis.
Understood. So I have a couple of audience questions. Dr. Carroll, Dr. Wagner, do you want to add anything to the current comment, or can I ask the questions?
I'll just add that there are certainly, we see a much greater deficiency among our preterm infants, and many of those are born to moms who are preeclamptic. And in South Carolina, our Black American women are at greatest risk for preterm birth, much, much higher, 18%, versus 12% of our white Caucasian women, and our Hispanic women are somewhere in between that. So I think that, you know, vitamin D has been linked with other acute infections, and but again, you have to have much larger samples to be able to show effect. But certainly, we do see gene effects that even in both the neonates and the mothers based on repletion.
Understood. Thank you very much. So a couple of questions from the audiences. One is Faraz. Faraz is saying, is the panel saying that prenatal vitamin D deficiency can cause permanent harm to infant like asthma and eczema?
I say yes.
Thank you. And then the other question, sorry, go ahead.
I've even seen studies that show an increased risk of, well, especially type 1 diabetes, but even further on, later in life for that child, increased incidence of breast cancer.
Understood. Thank you for this. Char says, what are good ways for people to test their own vitamin D levels if their insurance plan will not cover a vitamin D test?
You can do a home blood spot test with GrassrootsHealth.
Oh, so grassroots.
Yeah, that's what I was going to suggest as well.
And it's just
Understood.
a simple finger prick. You put it on a piece of filter paper, and it's a dry blood spot test. Mail it in, and you can get your vitamin D level. Understood.
Thank you very much. So we are nearing the end of the hour as well. I have a very important question to ask, which is kind of a summary of this. The topic main today, pregnant women, prenatal health, newborn health. What is your recommendation? What does the panel suggest? So imagine if somebody is going to conceive, or they have become pregnant, or they have a newborn. How do they look at all of this to say, what do I need to do?
I mean, this just isn't about pregnancy, okay? I think everybody should be taking enough vitamin D to maintain their blood levels above 50 nanograms. So that be it, 5,000, takes my wife 5,000 units a day. It takes me 10,000. It's quite variable, but it's not just about pregnancy. It's about general health and cancer prevention and other things as well. So, like I said, the only way you'll know it is if you take it and 3 months later you send in a blood test and you're there, and that's it. You're good. Stay on that dose.
Understood. Carol, what do you think?
So if someone is not able, they don't have the means to obtain a blood test, and I think we can safely say that that woman should take, and even the Endocrine Society in their report say that they can safely take up to 5,000 international units. And if a person is, doesn't go out and they're in a higher risk group, you can, as a physician, you can justify and order a 25 hydroxy vitamin D, but you would have to get that ordered, and you'd have to have a justification. But I do think you could safely recommend that. For lactating women, they need at least 6,400 international units to be able to have adequate amount of vitamin D that gets into their milk so that their babies are replete, so their babies do not need to be supplemented.
Understood. Thank you. Couple of more questions that are important. One is from Mrs. Ayers. She says, what do you suggest for vitamin D supplementation for newborn or children?
So newborns, the American Academy of Pediatrics has recommended for a long time now that in the first few days after birth that all newborns get 400 international units a day. If they are formula fed and they're taking less than 1 liter, which is about a quart, then they should also be supplemented with 400 international units a day. If they're taking more than a liter or about a quart of formula, then they wouldn't need to be supplemented. But I think that it's very safe for all babies through the first year. And then after that, the recommendation is somewhere around 1,000 to 2,000. And as they get into adolescence, they should really be taking the amount that an adult would take.
Thank you very much. Nick says, have there been any studies that look at autism and vitamin K status of the mother? Have there been any studies for children with autism and correlations with vitamin D status?
Yeah, there have been. There's been no randomized trials, but it looks like vitamin D could be a key factor in the development of autism.
Understood. Thank you. One more question just came in. Martha says, do either of the presenters have a public website that we can follow? Thank you, Dr. Wagner, Dr. Aliano, and Dr. Hollis for providing a wealth of new information and graciously sharing your experience. Thank you, Dr. Meen, for this valuable presentation. You're very welcome. So where do we find you? I think if we just write your name, we find you, but any specific sites that you would like us to go to?
I think personally, I always use GrassrootsHealth. And I feel that there's a lot of, the references are excellent, the recommendations that are made, and then they're followed by the references. I think that's a really good starting point. And I don't have a particular website. I would certainly, if you look for our studies, they're in PubMed and they should be available to you. But I do think a good resource that is really equipoised is GrassrootsHealth.
Got it. Thank you very much, Bruce.
And I do quite a few of these, and I don't mind if people email me at my university email address, and I'll always answer their questions.
Awesome. Thank you very much. So, Jen, any final questions from you before we break?
I just kind of wanted to reverse and touch on kids as they grow, teenagers. Like Dr. Hollis said, testing vitamin D, making sure you're getting the right dose is important at any stage of life. Personally, I have two teenagers. I have friends with teenagers, and a few stories about how vitamin D deficiency has affected their children. And once it was corrected, we saw great improvements. And there's actually an increase, like as you grow, as your child's growing, their need for vitamin D grows. So you can't just give them the multivitamin that only has 400 IU of vitamin D. And in my experience, you can't just tell your kids to take their vitamins. You have to actually put them in front of them and make sure they take them, which is another reason why measuring their levels is important. So in our own cohort, we have looked at vitamin D levels among children of different ages from 0 to 18, and their risk of deficiency increases as they reach their teenage years. And it's because they're not getting that higher dose of vitamin D that they need as they grow. And it can
Understood.
affect anything from their mood, their attention, their growth. It's just important for so many different aspects of their health.
Thank you. And I'm cracking up because my wife has to put the vitamins in front of me as well. So I guess that makes me a teenager too. So very good. Thank you very much, Dr. Wagner. Thank you very much, Dr. Hollis. Thank you, Jen. And I think we should talk more on various topics related to vitamin D. I know your time is precious, so finding you and getting you on the panel will be a problem, but I think that's a good problem, and we would continue to seek your messaging.
Yeah, I'll just add one thing is everything we've talked about today is physiologic. The levels of intake physiologic, people will disagree with us about it. They'll say, but everything we've talked about today fits into normal human physiology, not pharmacology. Pharmacology, such as how much vitamin D do you take when you have cancer or active, that's a whole different topic. Okay, that enters into pharmacology and would be a good topic to cover in another talk.
I love it. This is a very important thing to know, that this is physiological levels and mechanisms you're talking about. Pathology and then correcting the pathology will be altogether a different beast. So thank you very much. Carol, any comments from you before we break?
No, I just wanted to say that I agree with what Jen said, that, really, there are, the multivitamin 400 international units is what we give to a 3 kilogram, a 7-8 pound baby, and including also our preterm infants, they get the same. So it makes sense that as you grow, your requirements for this pre-pro hormone, unless you're going outside in the sun, right, which is a great source of vitamin D, but unless you have that and you're not using sunscreen, really you do need to increase your intake as you grow. And I think that point is really well made by Jen. And I also thank you for this opportunity, because we really want people to be vitamin D replete. And we're not talking about, super pharmacologic. We're talking about what the doses that will get you to levels that you would have if you lived in a sun-rich environment. That's really our goal.
And I have one more interesting
Please.
fact, just to piggyback on that. There have been studies by Lux Walda, right, on the African tribal populations, and they're getting plentiful sunshine, and their normal vitamin D levels are between 40 and 60. And can you guess which group within those tribes had the highest levels of vitamin D? It was the pregnant women. So pregnant women getting ample sun, getting ample vitamin D3, their vitamin D levels were naturally rising to meet their physiological needs and the needs of their baby. And so we really have to do everything we can to make sure that our pregnant women are getting enough vitamin D3, whether it's from the sun or from supplements because it's really hard to get it just from the sun.
Understood. Thank you so much. Thank you for your time, for the valuable insights, and really serving humanity messages. And I keep becoming disappointed at a general state of medicine and the way it is declining by not looking at the correct studies, by at least seeming to be taking sides which are not for the people's favor. So anyways, thank you very much for speaking. Thank you very much for sharing your information, and hope to see you again. Bye for now.